Okay. Hi, Tesh. This is your private DSM lesson intro to mental health, psychology, and I'm going to explain the DSM. Let's see if I can bring this closer. I'm going to describe the DSM to you, and I'm going to describe personality disorders to you in a very basic way so you can kind of get an idea, an introductory idea to psychology. So the first thing I would tell you is psychology and counseling, which is what I do, are actually kind of two separate things. So if you actually want to counsel people, you actually have to go to school for counseling. So something that's not understood by many is if you go to school and you get your master's in psych, it only takes about a year and a half, and that's primarily for research. So you can't do much with it. And a lot of people make that mistake. So for people who do that, they don't understand that, and then they have to go back and do a doctoral psych program. And that's more of a traditional old school way of doing therapy. And the foundation of my training was in postmodern therapy, and postmodern thinking is, just like it sounds, postmodern, means after the modernist era, which was like Freud. So we're in the era where we look at things as socially constructed. And so when you're beginning to understand socially constructed or social constructionism or constructivism, those theoretical ideas, you kind of need to understand those to understand how we counsel. So really what you're interested, I think, is in counseling psychology, right? So you want to counsel other people, but you also want it to be based in traditional psych because you're interested in the mind and analytics and how that works. So I'm going to give you kind of an introduction to that today. And I'm going to introduce you to, there's so much I could talk about, but this is a learning experience for me too. I'm going to start out by doing what you asked, which was to talk about the DSM. And I'm going to do that for you and explain personality disorders. And I also want to explain, some of the basic tenets of mental health and how we sort of determine whether or not there's a problem, because problem formation, deciding whether or not something is a problem is not as easy as you think. So for example, when is something a problem? Right? I bet you never thought about that, but something is a problem when you say it is. If it's not a problem for you, it's not a problem. It might be a problem for someone else, but if it isn't for you, it's not a problem. So let me give you an example. So let's say somebody, I don't know, is addicted to cocaine. All right. They live by themselves. They have a lot of money. They're smart about it. And they want to do coke. Is that a problem? And the initial reaction would be like, yes, that's a problem because it's dangerous and it's bad for your health, and the person could get arrested or they could get busted or they could whatever. But if that person is okay with that and they accept the possible consequences that could come with it, then it's not actually a problem unless they say it is, because they're not really in relationships with anyone. It's not affecting anything. So even though traditional psych would say, yeah, that person has a problem or they're an addict, in my theoretical orientation of counseling, something is only a problem when someone says it is. So when is something a problem? When someone says it is. If no one's complaining or doesn't feel that it's a problem, it's not a problem. So that's a very different way of looking at things. That's how we look at things in postmodernism and in counseling versus psychology. Psychology would say, no, that person has a problem. They're using legal drugs and there must be so many reasons why they do that. So I'm sort of a hybrid, somewhere in between, but I definitely lean way more towards the sort of open-mindedness of counseling versus psych. Okay. The other thing I think it's important to know when you're learning about psychology, aside from problem formation, how does something become a problem? Something else that I think is important to understand is, should I just lost my train of thought? Problem formation. Oh, and how do we decide if somebody needs treatment? So we look for something called the 3 Ds, and this is something you would learn in an intro to mental health class: danger, dysfunction, and disability. Okay, so let's go back to the isolated person who uses Coke and, has the money for it, doesn't have to work, has no relationships. So it's not really affecting anyone but him, and he's okay with it. So let's say that this man presented in your office, okay, came to see you as a therapist, or came to an agency or hospital where you were working because he started having a lot of panic attacks. So in our assessments, when we're meeting a new client, we always ask, do you use drugs or alcohol? If so, how much? Now, there's no guarantee someone's going to be honest with you, but let's say this man is honest and he says, yeah, I use Coke. I use a half a gram a day or a gram a day, or whatever. And you say, wow, okay, that sounds like you might be dependent. Do you consider yourself dependent on cocaine or not? Like, how do you see it? You want to know how the other person sees it. And if they're making a connection to using cocaine and then presenting with anxiety and panic attacks. Because as a clinician that there's a connection, but this person may not know that. So you need to assess them for danger, dysfunction, and disability. Okay, so let's go through that quickly. So disability meaning, because of the cocaine use, and we're thinking, we can't prove it, we're connecting that to panic and anxiety, is this disabling this man from doing anything? And we look at functioning with relationships, we look at functioning with family, with occupation, finances, all the health, all those things. So when you start to ask questions to this man around this idea of disability, you may find, and you may teach him that actually this Coke use is causing disability because maybe he's not sleeping, or he's not able to function because of his anxiety, or he's not able to sleep because he's so wound up from using so much Coke. And then in turn, he is unable to, get up and perform daily, the things of daily life, like get out of bed, take a shower, get things done. We don't know any of this, but these are the things you're looking for when you're trying to decide whether or not somebody has an issue. So you're going to assess for that disability. Then you're going to, what's even easier to kind of pinpoint is dysfunction. So is this person dysfunctional because of their Coke use, or because of their anxiety, or all two, or three, if he's having panic attacks? So you really have to ask a lot of questions in an initial interview, and you can't make assumptions really about anything to your patients or client, because you don't really know. So you want to find out, like, okay, is this anxiety and panic attacks, are these things connected to his cocaine use, or is it, behind why he's using so much? You've got to ask a lot of questions to assess, is there really disability? And obviously dysfunction, just meaning, he doesn't go out and get his mail, or, doesn't talk on the phone to anyone because he's, all high up on Coke. All right. Then danger is always the big one. So the 3 Ds: disability, dysfunction, and danger. So danger is an obvious one. Is this person a danger to themselves or others because of whatever this presenting problem is? And so this would be an interesting case to work with, because you have the patient presenting saying, that his Coke use is not a problem, but at the same time, he's suffering from extreme anxiety and panic attacks. So as a clinician, there's data and there's research to prove that cocaine causes these symptoms. But it could also be that he has social anxiety and uses the cocaine for that reason, or he has some medical condition that makes him unable to function, and so he uses the cocaine. All right. So one of the things about being a psychologist, a counseling psychotherapist, is you have to be very curious about people, and you kind of have to have the ability to sit with somebody with a very open mind and try very hard not to make any judgments. And this is how I would teach you. Okay. You don't want to make assumptions or judgments and jump off the bat and say the cocaine is the problem, especially if the client doesn't think so. Right? Because when is something a problem? Well, when somebody says it's a problem. So you would have to do a lot of interviewing, a lot of asking, and a lot of what we call intentional loitering, right? And we call get curious, to really find out the big scope of this person's life and understand what might really be going on there, and not jump the gun to say, okay, you're having panic attacks because you're not sleeping and because you're not eating and because you're using cocaine. Because we don't know that. That's an assumption. We can have that in our toolkit. We can have that in our brains from the things we've read and we've studied, but we don't know that that's this person's lens. So I think one of the most important things to remember when you want to counsel somebody is to not make assumptions, to stay open-minded, and to ask a lot of questions, especially in the beginning. Once you establish a rapport with a client over an extended period of time, then you can lay back and be a little more casual, and you get into a rhythm or a harmony of conversation and dialogue, and you know each other and you trust each other. But in the beginning, you really have to be as objective as possible. Okay. That being said, let's jump into the DSM. So let me grab it. Okay. So what is the DSM? I've done YouTube videos on this. I've probably talked to every client I've ever had has probably had this little lesson. But okay, what is the DSM? This is an older one. This is my favorite version. This is the Diagnostic and Statistical Manual of Mental Disorders. So DSM-4. All right. TR stands for text revision. It just means it's been revised, right? So there's a DSM 1, 2, 3, 4, 5. Okay. And I should know this, but I don't think there's a 6 out yet, but there could be, because it's been a while since I've really looked into it. But the 5 is very, to me, it's a little too much. I like the 4. And this is widely shared in European countries, as well as the United States, but it's not applicable in all cultures. So you have to remember that too, that, somebody who's from, a tribe in Africa, if they're reporting hallucinations or visitations from spirits, you can't go ahead and just diagnose them schizophrenic, because that's part of the culture. But in America, that's kind of the way it is, although even that's changing, as you and I well know. So this is a manual that we use as therapists, psychologists, and psychiatrists. We use this to diagnose people with a mental disorder. And I really don't use this book. If you don't take insurance, you do not need to use this book, but you should know this book, in my opinion. Very important. And it is a nomenclature, which means it's a list of names of things that is co-created and constructed by a panel of psychiatrists and psychologists. So it isn't fact necessarily like a medical diagnostic manual that will tell you, okay, if somebody's blood pressure is over 130, that's considered high blood pressure. And these are the risks that they have, which we know for sure because of research. This is different. Psychology is very abstract, and it's actually very new. We only have been around for a little over 100 years. So think about that. Psychology is very, very new, and we don't have a lot of things to treat and measure compared to the medical community. So psychology used to be an art and a science. You know, my degrees say they're in science, but I do look at especially counseling as an art. But I digress. So let's get back to this manual. So in this manual, this big, thick manual, mostly everything in here is considered a mental disorder. Mental disorders are considered treatable and temporary. So a very common mental disorder we all know of is depression. So if you're diagnosed with depression, we know that with therapy and or medication, that we can arrest the symptoms of depression, that eventually they'll end. Now, there are some people that really, really wrestle with some really severe depression, but for the most part, it is treatable and it is temporary. It's a state of being that can pass with treatment. Even schizophrenia, bipolar disorder, anxiety disorder, ADHD, all those common diagnoses we hear thrown around in pop culture, we see those things as temporary and treatable. Are they all easy to treat? Hell no. Would I agree that they're, temporary? Not really. If we're talking about certain mental disorders, like I don't really believe that schizophrenia is temporary, because when you have schizophrenia, we can look at a brain and we can see differences in the brain of someone who has schizophrenia. We can't do that with many other things, although we're working on it. So with schizophrenia, we know that there are brain differences with people that have it. We know that there's a genetic component to schizophrenia, and we know that it's very, very hard to treat. You might be able to arrest some symptoms. You might be able to stop the hallucination, the paranoia, and things like that, the depression, the ups and downs with some medication. But there's very few people who are functional with schizophrenia. There are some, but it's very, very few in number. So I look at schizophrenia as more of a permanent thing, but that's not how it's categorized in this book. Okay. So that meaning that if it's temporary and treatable, that we can get insurance to cover it. Okay. So when you take insurance as a mental health care provider, which fewer and fewer and fewer are doing, because insurance pays so terribly, you would starve if you took insurance. It used to be a very viable way to do it. It's not anymore. So if you are working with insurance, you must diagnose your client, even if you don't think that they're diagnosable. So for example, let's say somebody comes in and they're very depressed because they lost their job. Okay. Do we really need to diagnose them with depression? No, we really don't need to do that. And a lot of people don't want that on their record. So what we would do is we would diagnose them with an adjustment disorder. And adjustment disorders are a very tiny section in this book. But what's nice about adjustment disorders is they are exactly what they say. They are an adjustment in life, a big change in life, and you're having trouble adjusting to it. It's not, serious. And with some therapy, usually we can get over dealing with that change for most people, right? Bereavement is separate. It's not necessarily an adjustment disorder. It has its own category, but I totally disagree with what this book says about bereavement. We're not going to get into it. So let's go back to what you're dying to hear about. Personality disorders. So personality disorders are a very small section of this book. And I always show this to people so they can see how small it is compared to the rest of the book. So it's just this little tiny section. That's it. And there's a total of, I think, 13. Let's see how many. Okay, there's 10. I think in the 5 there's more, but there's 10. I'm going to read them out. So we have paranoid personality disorder, schizoid personality disorder, schizotypal personality disorder. Antisocial is number 4, borderline number 5, histrionic 6, narcissistic personality number 7, avoidant personality disorder number 8, dependent personality disorder number 9, obsessive compulsive personality disorder. I think I messed up the counting. And oh no, that's it. Okay. And then personality disorder not otherwise specified, which you can do throughout psychology and diagnoses all the time. So that gives you the flexibility that if you see something in front of you that kind of looks like depression, but it doesn't really fit what the manual says are the diagnostic criteria, you can say depression not otherwise specified, and you would get insurance coverage for that, most likely. And if you just see someone acting really bizarrely, but they function, so it's not like schizophrenia or bipolar disorder or something, it's some kind of weird personality pattern. You could always just, if you can't figure it out, you could say, okay, that's a personality disorder not otherwise specified. But usually, I mean, like, you can always figure it out. So what's fun about the DSM, especially when you're a new therapist, is you see all these presentations of clients coming into your office with things that you've never experienced before. And you have to kind of research and figure out, like, where do they fit? So I remember when I first graduated, I had this woman for years come to me for therapy, and she was extremely paranoid, but she also was, had a very severe case of bipolar disorder. So she was very, very depressed, and then she'd be very manic, and, she would fluctuate every 3 to 6 months. And she was also very paranoid. So what was interesting about her that I couldn't figure out is that even when she was reasonably medicated and functioning, no matter what was happening, she always had this odd paranoia about everything. And, I couldn't figure it out. And for months and months, I would try to figure this out. And finally it hit me, she's got a paranoid personality disorder. And I read about it, and it fit her to a T. And that was helpful because then I kind of knew what I was dealing with a little bit better. And I understood how to explain this to her family. And I kind of understood that it might never resolve because it was part of her personality. It wasn't just a delusion that she was cycling through. So you get a lot of these interesting cases, especially when you're starting out and you don't know what you're doing, and you see these really random presentations in front of you. And so that's how you gain experience, and that's how you understand psychology, and you start to understand this book better, and you can identify things, much more quickly. So this is one thing I'm really good at, and I think it's because I have a lot of experience, obviously, at this point. I've always known this book inside and out, even though I didn't have to. And I worked with a very large population of different types of people. I worked in a hospital setting. I worked in an agency setting. I worked in, and when I worked in the hospital setting, I worked in acute psychosis. I worked in general population. I worked in addiction. I worked with grieving children. I worked in a group private practice where we took insurance. And then eventually, once I went on my own, the cases became much less complicated because when people are choosing therapy instead of being mandated by law, to go to a facility, the cases aren't quite as complicated. You're not going to see, but that's why it's important to have experience, because that's how you learn. You learn in the trenches. You don't learn necessarily on a cozy couch. You learn on a cozy couch, but not the way you're going to learn when you're thrown into a psychotic, a unit with psychotic people. Then you're really going to learn. Okay. So when you're working the thing about personality disorders is there's 3 clusters: cluster A, cluster B, and cluster C. As far as the cluster A's are concerned, we're not going to get into those really. They're very unusual. It's like less than 0.5% of the population has these disorders. They're very odd, and they're kind of fun to learn. But I think what you're really looking for is you want to learn about the stuff that we all interact with, the people we marry, we live with, we're born to, we go to school with, we go to work with. And those are the cluster B personality disorders. And these are the ones that are very common. And those are the ones I'm going to talk about today. So those would be the antisocial, which doesn't mean like it sounds. So antisocial doesn't mean you don't talk to anyone and you have no social skills. It basically means you're a sociopath, that you have no empathy and you are not capable of feeling and interacting with other people in a way that is safe or healthy. Let's put it that way. These people can be violent. They can be con artists. They can be, and I'm not talking about a petty thief. I mean, I'm talking about severe manipulation and, really just conning people out of property, money, having trouble with the law, rape, abuse, violence. When we're getting into that category, we're talking about the antisocial personality. And then if we expand out from that, we're even getting into criminality, which I'm looking into. Oh my God, she's got my angel cards. Did you pull me a card? What card did you pull for me today? Oh no, you wrecked a card? Make a decision. What am I making a decision about? Oh my God. Get your power back. She chewed it up. God damn it. Okay. Puppies. Okay. What are you chewing now? He's chewing a bone. Okay. So let's talk about borderline. Okay, so borderline personality disorder, the simplest explanation I can give you is fatal attraction. If you remember the woman, the character played by Glenn Close in that very famous movie with Michael Douglas, she was obsessed. She was having an affair with Michael Douglas. And, he was pretty clear that he was married and, this was just an affair. And she went cuckoo for Cocoa Puffs over him and she stalked him and she became obsessed and her whole life became getting this man and destroying any other woman in his path. And she was like a very severe. But borderlines come in all shapes and sizes. But the hallmark of the borderline is fear of abandonment. So no matter what's happening in life, they always think that they're being abandoned or they think that they're being, played or not cared about. And because they really lack a sense of self. So they're very manipulative and they're also manipulatable because they tend to make their whole persona, their whole world about other people. And they're clingy and they have a hard time being alone and they always have to touch and be in contact. Like one of the funny things we say about borderlines is you always hear from a borderline, they'll follow you for the rest of your life. But borderlines can be cool. Like I know some really cool borderline people. It just depends to what degree we're talking about. So borderlines can be very excitable, very moody, but their moods never last more than a few hours. They can sort of disassociate. So if a borderline is very upset or very angry, they can just go into this weird, I've seen people do it, they go into this weird, shell isolative space for a few minutes and and then they'll come out of their hands and, they look like they're crazy. They feel everything very, very deeply. They have a really hard time controlling their emotions, and they're extremely manipulative for what they want. So what they want usually is a particular person. And so to get that particular person, they become very manipulative. They split and turn people against each other. So we call borderlines are often splitters. So for example, if you and I are friends, and I was talking to someone else who knew you, I would say, Jane, Tish said such and such and so about you. And probably I would totally make it up just to start a fight between the two of you. And, sometimes there's a grain of truth to it, but borderlines are drama queens. They exaggerate everything, and they love turning people against each other. They love, sometimes they're very rude. They'll just say things like, they love telling you like, oh, Elizabeth, did you know that Tish said something really nasty about you yesterday? And I'm like, why would you tell me? Like, why do I need to know? You know what I mean? So they're very inconsiderate because, and this is when they start to blend with the narcissist, is that, borderlines are really out for themselves. They're moody. They can be explosive with their temper. They get, like I said, this very disassociative, huffy state when they get upset, or if they think they're going to be left. They'll chase you. They're clingy. They always feel empty. They have no sense of self. Quite often, they become addicts of any kind. Drugs, food, gambling, whatever, and they can be extremely self-destructive and extremely risky. So, a borderline woman will, often, or man will just jump into bed with anyone, anytime, any place, and lie about it. I mean, again, this is a high level borderline. They're the lower level borderlines, like they're okay. They're fine. You and I are probably like lower level, like a 1, just meaning that we have had some of these traits, especially as teenagers, but we mature and we grow out of them simply because we had a lot of trauma as kids. So, but when the people who maintain these patterns in their adulthood, which, we know of many, they can really be really a pain in the ass, and they can be very hard to get along with. And another trait of borderlines is when you go through their relationship past, their relationship history, it's usually very, very rocky, unstable. They don't talk to their mom. They don't talk to their sister. They don't talk to their kids. They don't talk to this one. They had a fight with that one, and they become best friends with you for 6 weeks, and then they turn on you. And borderlines want to hurt you before you can hurt them because they are afraid of rejection and afraid of abandonment at all times. So just to give you the general diagnostic criteria for a borderline, let's find it. So sometimes I'll read these out loud to a client if I think they're dealing with someone with a personality disorder, so I can let them understand. And instead of me telling them, I'll be like, hey, well, let's just read through this diagnostic criteria and see what you, if you agree or you disagree. So diagnostic criteria for borderline: a pervasive pattern of instability of interpersonal relationships, self-image, and affects, which means moods, and marked impulsivity. I forgot about that one, the impulsiveness, beginning by early adulthood and present in a variety of contexts as indicated by 5 or more of the following. 1, frantic efforts to avoid real or imagined abandonment. 2, a pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. So let me explain that one. So borderlines, they hate you or they love you. They see things very black and white. They don't really have the ability to understand the gray of life. That, for example, there may be, a man who is a womanizer and, cheats on women, but he's a wonderful boss, he's a great father and a very philanthropic person, but he cheats on women. Is he all bad? I would say no. I would say there's a gray area there, right? He's not all bad. He does a lot of wonderful things, but you don't want to date this guy, right? You could be his buddy, right? So borderline would never be able to understand what I just said. Like they would be like, because they're very judgy. And yeah, so either someone's fantastic, wonderful, incredible, amazing, I love them so much, or I fucking hate them. And it can be the same person that they feel this way about day to day. So idealization, oh my God, I'm so amazing, wonderful, amazing, wonderful. And then Elizabeth sucks, I fucking hate her, I never want to see her again. And borderlines will go to major lengths to destroy you. They're the ones who complain online and write bullshit stories about you and talk poorly about you. And they just can't control themselves because they have such an unstable self-image and they cannot control their anger or their emotions. Okay. Identity disturbance, markedly and persistently unstable self-image or sense of self. Let me see how to explain that. So if you get into a relationship and you just forget about your whole life and existence and all you do is become obsessed with your partner, you can't work, you can't think, you can't function, and you have to know where they are at all times and talk to them every 5 minutes, and your whole life becomes about this person and everything else suffers. Okay. Because you have no sense of yourself, right? Impulsivity in at least 2 areas that are potentially self-damaging: spending, sex, substance abuse, reckless driving, binge eating, or self-mutilating behavior. So as I said earlier, borderlines are known to be very self-destructive. So they're cutters. They may have like tattoos absolutely covering every area of their body because tattoos are painful. So it becomes self-mutilating. Or like, when you see people with like big gauges and then like gauges all in their body, like, it's a couple of tattoos. Okay, it's cool. Piercings, great. But when you're covered from head to toe and you're destroying yourself through this, it's so extreme. That's a very self-mutilating, self-destructive. It becomes self-destructive. Starving yourself, throwing up after you eat, drug addiction, alcoholism, like all of these things that are very, very detrimental to the self, to the extreme. They're done to the extreme by the borderline typically, but not necessarily. Recurrent suicidal behavior, gestures or threats, self-mutilating behavior, that's the cutting. Always talking about suicide, threatening suicide, maybe even, threatened, did an attempt at some point. Affective instability due to a marked reactivity of mood, intense episodic dysphoria, which is that like confusion when you're like in this weird mood state. Irritability or anxiety, usually lasting a few hours and only rarely more than a few days. So yeah, borderlines are moody as all hell. Chronic feelings of emptiness. So they're always trying to fill themselves up with other people, gossip, other stories, drugs and alcohol, sex, gambling, whatever it is. They just can't be. And they're very destructive people. not to be trusted. Not to be trusted. Chronic feelings of emptiness. Talked about that. Okay. Inappropriate, intense anger or difficulty controlling anger. Example, frequent displays of temper, constant anger, recurrent physical fights. That speaks for itself. And then finally, transient stress-related paranoid ideation or severe dissociative symptoms. Now, it's very hard to understand when a borderline is experiencing this dissociative state of paranoia compared to somebody who is really paranoid, truly paranoid. So borderline paranoia might look like everybody's always out to get me. They're victims, borderlines are major victims all the time. Like, woe is me, everybody's out to get me. And I know that, they're cheating on me, or I know that they're, hey, Roxy. I know they're cheating on me. And there may be no basis for it, but they do so much of that themselves that they can't imagine that someone else wouldn't do it. And that's basically what we're looking at for borderline. So, I mean, I could go on and on and on. I realize how long this is. We're already at 41 minutes. So I'm going to stop here. And my dog is trying to, my puppy's trying to eat the toilet cleaner. Hold on a minute. Roxy. Yeah, you're so cute. You're so cute. Okay, so what I want you to do is listen, take your time and listen to this. It was actually a lot of information. And write me back with questions, or, send me a voicemail with questions. Because you're going to see a lot of, since I know you're going to see a lot of your relationships, a lot of the men you're in relationships with as borderlines. And by the way,